Welcome to Ask the Experts, Managing Asthma During the COVID-19 Pandemic. My name is Kafi Drexel-Brown. I am the Public Relations Director at the Asthma and Allergy Foundation of America, also known as AAFA. During today's 60-minute virtual question and answer session, experts from the Asthma and Allergy Foundation of America and Improving Pediatric Asthma Care in the District of Columbia Asthma Clinic at Children's National Hospital, also known as IMPACT DC, will help you to better understand how to take care of managing asthma during the pandemic, especially as we get deeper into fall and head toward winter. This virtual session is being recorded and may be distributed in whole or in parts following this live event. I'm joined by Kenneth Mendez, President and CEO of AAFA, Dr. Eduardo Fox, Associate Medical Director of IMPACT DC, Dr. Mitchell Grayson, Chair of AAFA's Medical Scientific Council, Dr. Shilpa Patel, Medical Director of IMPACT DC, and Dr. Deepa Rastogi, Co-Director of the Severe Asthma Program at Children's National Hospital, along with Dr. Bud Wiedermann, a specialist in pediatric infectious disease at Children's National Hospital. Topics for this discussion will include access to asthma healthcare during the COVID-19 pandemic, especially in the hardest hit communities, asthma management strategies, including preventing respiratory illnesses, making decisions for in-person and stay-at-home learning and work, and the role of telehealth in asthma management. Attendees are in listen-only mode. Questions have already been submitted by you, the audience, during registration for this event, but please feel free to further interact by submitting general questions and comments by typing in the chat. We will try to answer as many questions during the program as possible. If we're not able to answer your questions, someone will follow up with you afterwards. We can only answer questions of a general nature. The information presented today is not medical advice, and we encourage everyone to consult with their own healthcare providers. This program is one of the kickoff events launching an important partnership between AAFA and IMPACT DC to help tackle racial and ethnic disparities in asthma care nationwide by focusing on expansion of community health programs. So let's start off with a welcome from AAFA CEO Kenneth Mendez, also known as Kenny, who can tell us a bit more before we get into our official program Q&A. Kenny?
Great, thank you, Kafi. Can you hear me okay?
Sure can.
Yeah, great. Well, I'm really excited about the partnership between AAFA and IMPACT DC. AAFA just released our asthma disparities report. And it's a report we last did in 2005, so it's a 15-year look. And the gaps haven't really changed. Black Americans are 3 times more likely to die from asthma and 5 times more likely to go to the emergency room for an asthma attack than white Americans. Puerto Rican Americans are diagnosed with asthma twice as much as white Americans. So I've always seen IMPACT DC as one of the best-in-class community programs. Programs like this are exactly what we need across the US to fix those disparities. That's why we're partnering with them. One of the things that they do best is to empower the local community with information so people can take better control of their health, especially during times like these. So I hope you see by the content of this program, you'll learn and understand for yourself why programs like this are so important for our communities on a national scale. So Kafi, I'll turn it back to you, but thank you to everyone for joining us, and thanks to the panelists.
Thanks so much, Kenny. This all gets us right into our first set of questions related to our chat with our panel of doctors today. Access to asthma healthcare during the COVID-19 pandemic, especially in the hardest hit communities across the nation. Dr. Patel, as Medical Director of IMPACT DC, let's start with you. What are some of the things you've been seeing and experiencing in practice, and how can community health programs help?
So first of all, I just want to say we're also very excited to partner with AAFA, and I'm excited to meet other programs similar to ours who are in other cities and to come up with a best practice model so that we can make it easier for cities to implement programs such as Impact DC in their own cities, where they can partner with local community health programs as we do and their local governments to really improve the care of children in their communities. Especially during the pandemic, to answer that question, I think I would look for community resources. During the pandemic in DC, for sure, the Impact DC helps connect families to programs that are available either through the schools, in terms of schools being at home and food resources still being available at the schools, as well as through other, to address other social determinants of health. We have started a healthy housing video visits, which help families still work on home triggers, and children are spending more time at home, so this becomes even more important. One thing I am seeing, I work primarily in the emergency department, is children waiting a little too long to come to the emergency department. And I want to stress that it's really important to continue your medications, even when they're fairly well controlled at home and not getting sick as often. And I would say that emergency departments, at least ours, and I'm sure many around the country, are experiencing lower volumes, and therefore it's still very safe to go in the emergency department if you feel you need to go. So consult with your primary care doctor, keep your primary care doctor visits, and then if you do need to go to the emergency department, don't delay.
Got it. Thank you so much, Dr. Patel. Dr. Grayson, we've received a lot of questions from our community on this topic. I'm going to start with a question from Brianna in California. Can you discuss the impact of COVID-19 on asthma patients? And a related question from Francie, who's a parent and/or caregiver in Pennsylvania. Is there any current data about how kids with asthma are doing if they get COVID-19?
Well, thank you, Kafi. It's great to be here. These are important questions, and there's been a lot of confusion around this. And unfortunately, the CDC has not helped us with this. So what I would tell you right now is, based on what we've seen in the literature and what people are seeing, that asthma is not a risk factor for severe COVID-19. It's not a risk factor to get COVID-19. It's not protective either. That means you do just as well as you do if you didn't have asthma in general. And I say that because there have been 2 studies that suggested that having non-allergic asthma might make your risk of having more severe disease greater. But both those studies actually use the same data set out of the United Kingdom. And so I'm taking that more as likely that that data set is a little bit different than what the other data sets are that we've seen. And in fact, I didn't go look at the number of studies right now, but it was over 20. It's probably now closer to 30 that have actually shown no risk for people with asthma. So the impact of COVID-19 or having asthma and getting COVID-19, you're not likely to do worse from that standpoint. So that's good. Now, the flip side of that is that we're seeing fewer people having asthma exacerbations during the pandemic. That's probably a result of these things, and wearing masks and physical distancing. But for whatever it is, and my pulmonary friends have given me a hard time and said, you know, allergens haven't changed, so now allergies are not important in asthma, which is not really true. But it's probably because people have been, you know, doing this physical distancing and wearing masks, and that's helped. So we don't see COVID-19 or SARS-CoV-2, the virus that's responsible for COVID-19, causing asthma exacerbations, which is similar to what we saw with SARS and MERS. So that's the good side of things in terms of the impact of COVID-19 in asthma. And then the data in terms of kids, there really is not a whole lot out there, but basically they appear to be doing just like kids without asthma that get COVID-19. So again, there isn't any worse disease, there's not better disease, it's just the same.
Yeah, so Dr. Grayson, one other thing, 20 to 30 studies you say about so far, is that significant, or does that tell you that this is still pretty early on with more information that needs to be discovered with this as a new coronavirus?
Yeah, so these are early on studies. They're all retrospective, which means basically people are going back and looking at someone's chart and saying, okay, you got hospitalized, what happened, whether you had asthma or not. They're not the best studies. What we like are what we call prospective studies, where we enroll people forward and we watch what happens to them. those really haven't been coming out yet. We're still relatively early. A lot of what happened with this is really, as you know, that our healthcare system was somewhat caught off guard with this, and the initial reporting was not as great as we would have liked for public health data. And so asthma's got rolled up into lung disease. And one thing that has come out is that chronic obstructive pulmonary disease, which we don't see in kids, but in adults, is actually a risk factor for more severe COVID-19. And so that is probably part of the issues that got lumped in early on because they're just people rushing to try and understand what's going on. As we get further out, we're going to get those prospective studies following asthmatics forward and things like that. But again, because there's been so many studies, you would think that we would see an oversampling of asthma patients in those hospitalized with COVID-19 if it was leading to more severe disease, and we just don't see that. I will say that we do see in some institutions, there's been at least 2 that I know of, that have reported data that say if you have asthma and you're intubated, in other words, they put you on a breathing machine with COVID-19, you will end up staying on that breathing machine for an extra day than if you didn't have asthma. Now that's at 2 separate institutions. There are a bunch of other institutions that didn't see that. And again, I think that probably relates more to specific local differences in how they handle people with asthma rather than having anything to do with COVID-19. So that's a long-winded way of saying we don't have the greatest data in the world, but of what we've got a lot of it, and it doesn't seem to have any risk showing.
Got it. That's really great, useful information and something to definitely keep an eye on. Dr. Patel, the next question is from Pat in California. What can you do if you're having respiratory problems and you aren't able to see a specialist to get a diagnosis?
I think I would stress again the primary care relationship. If you're having any respiratory problems, I would first seek care with your primary care doctor. If you're having trouble, if they referred you to a specialist and you're having trouble getting in to see them, again, I would go back to your primary care specialist because they're probably going to be the best at helping you get the care that you need and deciding how urgent that care is. If it is more urgent and you're having difficulty breathing, shortness of breath, a difficulty with daily activities, then you can even talk to your primary care doctor about seeking urgent care, and they can tell you the best way to do it. I would also stress that a lot of specialists are still doing telehealth visits. And so you may not be able to get the diagnostic testing right away, but at minimum, get a telehealth consultation with that specialist so you can decide and come up with a plan of what to do best.
Okay, great. I'm going to stick with you for this next question from Sylvia in California. What preventative measures could protect me throughout this pandemic until a cure or vaccine is well established? Also, what masks are of good quality that don't make it hard to breathe and set off your asthma?
For the first question, I would stress what everyone's been stressing over and over again. So masks, physical distancing, and good hand washing, and keeping yourself out of crowded situations. So really trying to limit your exposure to any potential COVID is where I would go with first. And the second question, in terms of masks, there's been a lot of debate, I think, more in the general media about masks and asthma. I would stress there's no contraindication to wearing a mask if your child has asthma, that they should still wear a mask. And if you find that they're having difficulty breathing with the mask on, talk to your pediatrician. Some of this may be poorly controlled underlying asthma and symptoms that they have that are exacerbated by putting on a mask, but not necessarily because of the mask. I don't think there's any mask that I can recommend. There's nothing that's been put out there. I would really just talk to your physician about the specific mask that you're trying with your child and go back to them.
Thank you. Dr. Grayson, do you have anything to add here? I know that obviously through AAFA, we've recommended to the community that they look at masks that fit them well, that are comfortable, that come with multiple breathable layers. Do you want to add to that a bit more?
Yeah, just a few things. So I would say that you want to avoid, where people get into trouble and they don't think they can breathe through the mask are the tight-fitting masks, and that's what an N95 mask is. And you shouldn't be getting an N95 mask because we want to reserve those for healthcare workers. But those kind of masks that are tight-fitting are going to make it more difficult for you to breathe. the traditional cloth masks, the cotton masks that people have, that people are wearing, those really don't restrict your breathing at all. And so it's really a matter of finding one that fits, that you feel good having it on your face. So cotton masks are usually perfectly fine. Surgical masks, if you can find a surgical mask, usually fit relatively loosely around this part of your face because they've got the nose clip. And so any of those will work. And it's a matter of finding what you feel comfortable with. And remember that whatever mask you use, just hold it up to the light, make sure you don't see light getting through it. Because if you can see light getting through it, that means when you're breathing out, all of those particles are going right on through it as well, and it's not doing anything. So you want to make sure you can't see through it. And then the last thing I would say is, and actually this is, I think, a good piece that's on the AAFA website about it. If you have a mask with a valve, you don't want to use valved masks as long as that valve goes all the way through. And I think the AAFA site actually has a picture of, there are some cheap masks that you can get that actually have fake valves. It turns out because they have the cloth on the inside that covers over the valve, they're actually fine. Now, I don't know what, you may get some people looking at you a little askewed because you have a valve on your mask, but so in general, probably easier just avoid those valve masks. But I think really the bigger issue though is if you are having problems breathing, as Dr. Patel said, then I would say contact your provider, because that shouldn't happen with these masks. They're just not that tight and they don't really restrict breathing.
Yeah, and that valved mask, by the way, you want to avoid that because it can let respiratory droplets out, correct?
Correct. You're not, remember, we wear masks not to protect ourselves. We're wearing masks to protect everybody else. We're doing it out of our civic duty to protect the other citizens. And so if you have a valve, if you have someone it's just going to let everything go right on through. Those masks are really designed to protect the wearer from outside stuff, and that's a different approach. And that's sort of the same thing with the N95. So.
Yeah, and I've been seeing a lot of people lately with their noses hanging outside of their masks. Do you guys want to also quickly take up why it's so important to cover both your mouth and your nose?
Well, how do you breathe? If I put this way, I'm breathing through my nose, it's going everywhere.
Right.
And you don't want to do that. So your nose has to be covered. By the way, also when you take your mask off, do it this way. Don't grab the front of your mask. Just a little minor thing to remind people. But no, I mean, you breathe through your nose. That means anywhere that air is coming in and out, you want it to be caught by the mask.
Perfect, thank you. Okay, so I'm going to move on to the fact that having an asthma action plan and making sure it's updated is something that you all emphasize. Dr. Fox, can you talk about why this is so important?
Absolutely, great to join you all today. An asthma action plan is really just, it's common language, right? So we're all gonna have the same information. And it's really a way for, us as doctors and providers and families and school nurses and asthma educators to communicate exactly what we know about your child's asthma or your asthma, and being able to then tell people, these are, the asthma action plan on the side has symptoms that you want to be looking for. In the part that we write in, it tells people what medications and what doses they should be using depending on how they're feeling. And it gives you a plan for what to do as your symptoms possibly get worse, but also potentially get better, right? And so it's really, I call it just a recipe, right? And I do feel like it's really important. It also has another valuable tool about an asthma action plan or aspect would be that it gives potentially people permission to talk to each other. So I find asthma action plans that have some sort of consent on them that allow, for example, your doctor or provider to talk to the school nurse is really helpful. And some jurisdictions have that as well. So again, it's just a great tool that we all use. It will list a lot of information specific to you or your child, and it tells you what to do as things get either better or worse with your asthma.
Okay, great. We have a follow question, Dr. Fox, from Joan in New York. How often should my asthma management plan be reviewed?
That's a great question. So in general, we recommend that individuals with persistent asthma be seen about every 3 months just for a general follow-up, right? And those visits are going to be a great opportunity to review the asthma action plan, make sure it's still current, see if you have any new information. So I try to update it at least at those visits. For children, we do well-child visits as well. I take advantage of, when I'm doing my primary care, take advantage of those visits as well to update the asthma action plan. The other time would be, for example, if someone came in for an acute visit and you ended up changing medications or changing the plan, or perhaps, you know, based on the information you're getting that day, the family and I decide that, you know what, we're going to go ahead and start having you do albuterol before you exercise, right? So there's a space for that information to be included on the asthma action plan. And so we want to go ahead and update the asthma action plan and make sure we convey to the family that we want them to share it with school, right? Or even better, if there's a way, again, if we've had consent to share information with school back and forth, we can go ahead and potentially send that to the school health suite as well. And so any time we change things around, and we want to make sure it's reflected there, and it's really important to date the action plan so we sort of know which one is the most current one.
Okay, so this next comment and question is from Jacqueline in California, and it dips back to this discussion of masks, but I think that it's also related to what goes into your asthma action plan as well. She says, or Jacqueline says, I am required to wear a mask in stores and outside in town. I noticed that after about a half hour, I'm getting light asthma. I use blue surgical masks. Question, what should people with asthma do if they feel symptoms when wearing a mask?
Yeah, I think this was hinted at earlier in the sense of, generally speaking, we should be able to wear a mask without having trouble breathing. And so if you're experiencing any kind of trouble breathing after some period of time with your mask, I would raise that with your healthcare provider and just double check and make sure that we're doing the right things as far as controlling symptoms. And so one thing potentially you could do, depending on how you're feeling, is perhaps use your albuterol before you go and do these indoor store trips and that kind of thing, to see if that helps. But if that helps, it still, to me, raises the possibility that maybe we should be doing something a little bit better with your daily or your controller medications. And so I would just bring that up with your healthcare provider to consider what to do. I will tell you that when I'm wearing my mask, even just a regular surgical mask in the office, sometimes if I've been talking a lot, which in the situation might be happening, where after a while, like, I gotta catch my breath a little bit, right? And so just slowing down with your talking, taking a little bit of a deeper breath as you're talking may also help with that sensation of air not moving quite as well around your face. I mean, clearly it's a different airflow, right, when we're talking with masks or wearing masks than when we're not. And so if you find that perhaps just slowing down, that would help you, that's good. If you're outside and you're socially distanced enough from other people, it's okay to sort of take a break from the mask for like, you know, however long you need, a minute or so, put it back on and then proceed.
Yeah, I also like the idea of, if you're outside and able to social distance, to still carry a mask with you in case you interact with other people, than to make sure that you're able to put it on to protect others and to protect yourself. So thanks for that, Dr. Fox. Dr. Rastogi, can you tell us more about what patients and caregivers need to know about the use of inhalers, technique, and even why there's preference over nebulizers at this time? Let's start with a question from Tiffany in Colorado. Tiffany asks, is there a risk of airborne transmission with use of rescue inhalers with or without a spacer?
Yeah, hi everyone, it's good to be on this panel. So Tiffany asks a very relevant question. A lot, as was alluded to by Dr. Grayson, we are actively learning about the disease. So what we know thus far, the risk of airborne transmission is less or minimal with the rescue inhalers. Now, the thought there is that the respiratory effort that an individual is making, particularly when they're using it with the spacer, there's no active exhalation outside, right? And then especially when you're using, so if you're breathing in and out through the mouthpiece, or for children, we prefer to give them the mask, as compared to those that, you know, obviously deal with children with asthma, you realize that when you use the nebulizer, you can literally see all that mist going around. So what we can comfortably say is the fact that yes, the inhalers are safer and are obviously, so what is not COVID related, but is extremely important to highlight at this time is the fact that rescue inhalers are also the better way to use albuterol. So you get better drug delivery, it's faster, you can move around with it, it's portable, kids can take it to school, not that they're going to school everywhere right now. But all in all, inhalers are actually a better way to administer albuterol. And in the current COVID season, if anything, they're safer.
Okay, got it. And so a school nurse named Carrie has a 3-part question, and let me know if you need me to repeat any of these, Dr. Rastogi. Number 1, what is the best alternative to nebulizer treatments in a school setting? Number 2, can you reuse inhalers for multiple people if sterilized in between and each person has their own spacer? And number 3, is nebulized medication an aerosolizing procedure?
Sure, great questions. So yes, the best alternative to nebulizer treatments is the use of an inhaler with the spacer. Again, given that the aerosolization that occurs through these nebulizer treatments is phenomenally higher than any that may occur through the inhaler. Regarding reuse of inhalers, ideally, you would want every child to have their own. Again, a lot of this stems from the fact that honestly, we don't know enough. Everything that we are dependent on as clinicians and as scientists is dependent on literature coming out. And when you think of the many aspects of COVID that we still don't know, and recognizing that children at least are doing better than adults, and asthma doesn't seem to be, an at-risk factor, then research specifically on medication delivery for children with asthma is not the top priority, and therefore is not, we're not getting reads on that. So, so that's, one has to recognize the limitation of the data and literature that we know thus far. And in the realm of that limitation, ideally you would want every child to have their own inhaler. In the absolute dire situation, you have a child who's having an asthma exacerbation, you have a sterilized inhaler. I can say that, if I were basically the do no harm, if I was comparing the risk of transmission of using one such inhaler that has been sterilized versus obviously having the child breathe better, I would take the child breathe better and I would use it. Would I use it routinely? Most likely not, only because we have no clue at this time regarding the deposition of the SARS-CoV-2 virus on these different apparatuses. You read different papers, you get different data. So people talk about, the virus surviving on surfaces for 24 hours. You read, elsewhere, and it's whether it's plastic or it's wood. It's very difficult at this point in time to conclusively answer the second question. And the third question we sort of addressed a little bit early on, where we said, yes, the nebulization is absolutely an aerosol generating procedure, which is why there was rapid transition towards using inhalers, which led to this, obviously the shortfall on having albuterol inhalers be available, just because they were being used up so much more in the hospital setting, ED settings, which may have used the nebulizer model inhaler in the past. So if there is a choice, and again, given the benefit of having a spacer with a meter dose inhaler specific to the child, whether the nurse keeps it or the child carries it in their bag, I think is the best way to move forward with managing asthma in the school setting.
Yeah, thank you so much for that. And on part 2, basically also what you're saying is really best to err on the side of precaution, especially in this, of caution rather, and especially in this environment, and only in an emergency do no harm situation might you consider that technique, right? Dr. Rastogi?
Yes, yes.
Okay, got it. Okay, so we've seen how employing effective asthma management strategies is so important. Let's dive in deeper with Dr. Wiedermann. You specialize in pediatric infectious disease. Can you talk a little bit more about the role this can play in preventing respiratory illnesses and what people need to be especially mindful of right now, including getting their flu shots?
Yes, thanks, Kathy, and good afternoon to some of you. Good morning to others. Very pleased to be invited on this conference. I love questions about prevention. It's a lot easier to prevent an illness than to treat it, and it's the key to everything in medicine. So that's great. I'm going to sound a little bit like a broken record because we have, you know, sometimes we all feel out of control in the midst of this pandemic, but we have some very simple things under our control that really help. And that's hand washing, wearing masks, social distancing. And that's a relatively easy thing to do. Protects us, protects others. So I can't stress enough how important that is. And it's sort of been a pleasant surprise to me how well these simple procedures seem to work in preventing spread of SARS-CoV-2. Flu vaccine. Lots of stuff out there about flu vaccine, all vaccines. It can be pretty confusing. Bottom line is flu vaccines work, and they especially work to prevent complications of flu, the more severe illness. We have no idea what our flu season is going to look like here. We've seen already in the southern hemisphere where they're already winding down on what is usually their flu season. They haven't had much influenza, perhaps because things were shut down so much. That would be nice if it would be great if it happened in our country, but in the US, we haven't shut down nearly as much as some of those other countries. So I don't know what to expect with flu, and I think we have to plan that we're going to have a significant flu season. So if you haven't already, please talk with your primary care providers. Get as soon as this webinar is over with, get on the phone, ask if you haven't gotten your child, your family immunized, everybody in the household. It's so important.
Got it. So the next question comes from Angeli in Massachusetts. Any updates on asthma guidance advice for those worried about getting the flu shot? She's also looking for nebulizer guidance and updates. So Dr. Rastogi, can you also provide some pulmonary insight here as well? Dr. Wiedermann, let's start with you.
Yes, well, I think it's been said somewhat, but let me say it again. Continue with your asthma management plans. There is nothing that should change because of COVID-19. All your regular treatments, whatever is working, keep up with it and keep in contact, reviewing your asthma management plans, as Dr. Fox has said. So all of this is very important and doesn't change. Flu shots, people have various concerns about. You probably know there's one vaccine that can be given sprayed into the nose. That's a live virus vaccine. The others have killed virus or parts of virus. The live virus vaccine, mostly because it's sprayed in the nose, can cause problems in individuals with wheezing illnesses. So a lot of people with asthma, for various reasons, shouldn't receive the nasal flu vaccine. And again, that's something you should talk about with your primary care provider. Otherwise, it doesn't make much difference which flu vaccine you get this season. Just get one. You might have a little pain at the site of the injection, rarely a little low-grade fever, but it's nothing like getting the flu itself, and you certainly can't get the flu from the flu vaccine. So that's definitely misguidance out there, depending on what sites you surf.
Got it. Dr. Rastogi, anything more on nebulizer guidance and updates, or do you think that we've pretty much covered that?
I agree, and thank you, Dr. Wiedermann. I cannot reiterate enough what Dr. Wiedermann has just said. Adhering to your regimen is key. If there's one message we take out of this, it's adhering to the current regimen. It's keeping you under control. Just keep taking your medications. It's very easy to slide and say, hey, I've been under good control and I've not had my asthma, and therefore my asthma has gone away or has gone away for 2020. And there are competing interests as well, right? We are all under a lot of stress, but just remembering that twice daily medication, those that are on controller medications, if they can just continue that every single day and reach out to their primary care providers or their specialists, whoever they're working with, to keep their asthma under control for refills well in advance, so that they have the time and the pharmacy has the time to give them the medications before they run out of it. Again, cannot reiterate enough the role of the flu shot in preventing flu in an asthmatic with or without COVID is bad. So it's very important to get the flu shot. And yeah, I think we've discussed the nebulizer use ad nauseum, so I'll stop there.
Got it. Dr. Wiedermann, this next question from Lori, who's a school nurse in Pennsylvania, is a really, really big one on top of so many people's minds right now. And to ask you this question, we're going to put up our symptoms chart that the Asthma and Allergy Foundation has put together that people can access online at AAFA.org. And the question is, how do you tell the difference between COVID-19 and an asthma flare-up?
Yes, what a great question. I'm so glad you have these charts and other resources on your websites. They're very helpful. Of course, there's a lot of overlap between asthma symptoms and respiratory virus symptoms, any respiratory virus, not just SARS-CoV-2. So especially coughing and shortness of breath and things like that. Focus though also on some of the other things. So fever obviously isn't going to come from an asthma attack itself. It's likely to be some infection, not necessarily SARS-CoV-2. But if you have other things like muscle aches, severe headache, especially for COVID-19, loss of taste and smell, although that doesn't prove that you have that virus, it's strongly suggestive. So the more of those things that sort of stack up, the more likely it is you could have SARS-CoV-2 infection. Bottom line, again, is talk it over with your primary care provider, and they will work with you to make a decision. Do you need to be seen in the office or elsewhere? Do you need a test for SARS-CoV-2 or for influenza? These are all important concerns, and I would say just if you're not sure, and certainly if there's a degree of discomfort, please consult with your primary care provider.
Okay, so our next question is from Tammy. She's a school nurse in Massachusetts. I would like to learn more about new suggestions on asthma treatments related to COVID-19. Dr. Wiedermann, why don't you take this? We're going to also have Dr. Rastogi weigh in on this one as well.
Yes, I'm not sure exactly what Tammy is referring to. There are a lot of treatments for asthma and other things that also work in to help certain aspects of COVID-19 illness. And again, I think everyone is referred to that we're still learning so much about this new infection. But some everything from steroid medications to aerosol treatments to when do we use a ventilator, assisted breathing for someone with very severe COVID-19. Those are all treatments that have been used in asthma and other respiratory situations, and they may be used slightly differently with COVID-19.
Now, Dr. Rastogi, is that the case? Is what's being used differently? Has anything significantly changed at this point?
Yeah, I completely agree. Again, Dr. Wiedermann makes it easier for me. It's essentially that there are no big changes. What we do know, based on these retrospective studies that have been done, is steroids, for instance, were of concern. That is a medication. The oral steroids by mouth are particularly given when someone has an acute asthma flare. So there was concern about what it would do in the setting of SARS-CoV-2 infection. We now know from these retrospective studies that individuals with asthma tolerated the steroid administration well. In fact, it helped keep their asthma under control. So again, given the literature that we have at this time, we are comfortable saying if there is an asthma episode, please do go on to manage it as you would in a non-COVID-19 time. So you would want to first start off with the albuterol. If albuterol alone is not bringing it under control, you would want to reach out to your primary care doctor, to your specialist, and get that steroid course. So that is known to be safe. Regarding existing asthma treatments, such as the controller medications, again, there has been no report thus far that they make the individual more susceptible to getting COVID-19. Yet, and obviously, like we said, on the contrary, it helps to keep asthma under good control, and good control of asthma keeps you protected from having, obviously more respiratory symptoms if there was to be an infection with SARS-CoV-2. So if anything, we have only to gain by continuing our medication and seeking care early, as Dr. Patel mentioned. The delay that we are observing may also potentially be contributing to some complications which can be avoided with just timely, accessing healthcare in a timely manner.
Okay, got it. So yep, go ahead.
For one other thing on this is that I don't know if you're going to have a question about, but I was going to say biologics as well. There's no evidence for any of the biologics we use, so anti-IL-4, anti-IL-13, anti-IL-5, anti-IgE, none of those that we've seen any risks related to COVID. The treatments are the same. You keep getting your therapy. And in fact, a lot of the companies now have the ability to get your therapy at home, so you don't even have to come in. So those would just fit with the whole thing, that all your controller medicines you would want to continue taking.
Okay, great. Important to know. The most questions we have do center around making decisions for in-person and stay-at-home learning and work. That's our lives these days. Questions and planning related to in-person and stay-at-home work and school during the pandemic are among our community's biggest concerns. For those tuning in who have not seen it, AAFA has even produced a useful resource, the COVID-19 and Asthma Toolkit for Schools. This helps both families and educators make vital decisions, do some individual risk assessments, and plan. You can see more information on how to access our toolkit with the slide on your screen. And I'm going to move ahead actually to this next question from Victoria, who is a parent and or caregiver in the United States. Is it better to do remote versus in-school learning? Dr. Patel, how do you make the decision whether you should send your child back to school? Something to discuss with your primary care physician? What do you say about this?
Definitely something to talk to your primary care physician about, but also kind of to understand what your own situation is. So is your child doing well with remote learning, or are they struggling with remote learning? Is it something to factor in? Do you have family members at home who are particularly high risk for COVID? So those who are older or those who are immunocompromised that were mentioned earlier. What is your situation? What are you able to sustain in remote learning in terms of your work situation? So I think all of these things have to be factored in. And then a conversation with your primary care doctor will help factor in the asthma-related symptoms. So is your child's asthma well controlled? What is the past look like for your child in asthma in terms of fall season? Were they admitted? Were they in the ICU the last fall? Are they well controlled now? Is it different than it was last time? So I think all of these factors need to be weighed in terms of pros and cons of remote versus in-school learning. And I think every family will have a different answer in terms of, even in your own risk analysis, as a parent, are you really anxious? Does it really make you that anxious to send your child to school? So your well-being and your mental health also have to be weighed in.
Okay, Dr. Grayson, the next question from Susan, I think, is one that we've touched upon a bit with regards to returning to in-person learning. She's a school nurse in Maryland. She wants to know the best type of mask for students with asthma to wear, what's best for teachers with asthma. And she's also wondering about what material the mask should be made of. We've touched on a lot of this. Is there anything that you'd like to add? She says that she does have a teacher in the school who is having difficulty talking with her mask on.
So I went for that piece. I would say try different masks. That's probably the issue in terms of what they don't like the kind of mask they're wearing. But the bottom line here is you really want a mask that is going, like I said, it's going to trap the particles that are coming out of your mouth and your nose. And a cotton mask is perfectly fine. A surgical mask is fine. I would not recommend N95 or KN95 masks because, again, those are going to be tighter and we want to use them for healthcare workers. The rules, the physical distancing, the washing your hands, the wearing the mask, it all same thing applies in the schools. You just have to do it religiously and make sure you stay on top of it. And it works. I mean, we're seeing it work in New York. It will work if we do it.
Got it. Dr. Fox, anything else families should be considering on their checklist, like having medications ready for when more students return to school or being aware of trigger control?
Absolutely. We've been certainly filling out a lot of asthma action plans and sending refills and prescriptions, your second inhaler, your second spacer for school, just so those are all ready to go. I understand that obviously we have an audience from all over. So some individuals are in jurisdictions where they're already going to some in-person learning, and others, similar to us here at DC, virtually no one is going in person yet. And so I think the other thing I would mention, just because we have been getting requests from some schools and some jurisdictions to actually provide clearance for the kids to attend school. So you might run into that where your school might be asking, because your child has a history of asthma, there is this perception that they need to be cleared. And we've had this request from daycares, preschools, and school systems. And so just double check. We have a pretty generic letter that essentially says that these are individual decisions to be made by individual families because of the lack of evidence so far for risk that was discussed earlier. And so for the most part, there's going to be very few kids that we're going to say shouldn't attend based on their own health. And as long as you have a scenario that's well controlled, that their kids should be able to attend school. But there's a lot of other factors to consider, like Dr. Patel referred to. But just be aware that there might be that extra documentation that is requested.
Okay, got it. And doctors, I want to let you know we have about 12 minutes to go, but Dr. Fox, I want to quickly ask you a follow-up with this because we're talking about returning to in-person school and work, but a lot of people are still at home and doing everything at home. Have you had anybody in practice coming to you saying that they're noticing differences with allergens in their home, or do you want to address quickly the importance of addressing indoor air quality while people are spending more time at home?
Yeah, certainly. This is, we're having a little bit of some folks feel like they're a little bit better off, and then other folks maybe not so much. And so the individuals that, maybe their triggers were related more to their school environment or their work environment, they're doing a little bit better, perhaps because they're not spending as much time in those settings. Whereas if your triggers are more present in your home environment and spending a lot more time there, and so thinking a little bit through your dust control and pets and pests as far as potential triggers, and then I do have a number of families who live here in the city in basement apartments, and sometimes water damage and mold can be an issue for those kids and families. And so really, if you're noticing an increase in your symptom, it's a great time to talk to your provider and just, run that sort of checklist around what could be in the home that's possibly causing a problem for you.
Okay, great. Dr. Rastogi, going back to the school environment, Tisa, a school nurse in Maryland, is asking about any new precautions inside of school as it relates to stock peak flow meters with individual mouthpieces. I think that we've hit on that a bit, but also can you talk about risks possibly to care providers assisting students with nebulizers and inhalers? What should they be keeping in mind?
Sure. So again, peak flow meters, because the individual is blowing into that equipment, which is the common part. Yes, the mouthpiece is an individual, but there may be deposition. Again, we just don't know, I think. So at this stage, if especially in the school setting, nurses can move more towards symptom perception and objective evaluation, looking for wheezing, and obviously, if there's retractions or other signs of difficulty breathing, then I might defer to using those signs of an acute asthma flare rather than necessarily, being dependent on the peak flow meter, just for the potential of, avoiding an exposure. Regarding the care provider assisting students with nebulizer, inhalers are obviously the safer way to go. If a child cannot tolerate the inhaler for whatever reason, and a nebulizer has to be used. So first and foremost, let me backtrack and say, as Dr. Wiedermann had mentioned, prevention is the way to go. So in a medical care setting, which extends to school clinics as well, the nurse wearing the mask at all times is, again, the best practice. For instance, here at the hospital, for me doing a regular outpatient appointment where I'm not anticipating the patient to be sick, I have my full protective gear on. So just wanted to preface the response to the second question with that having a protective gear on is the best way to go. And then obviously inhalers are safer than nebulizers. So suppose there's extensive nebulizer use, if Tisa is in a primary school where the children may be younger, may not be able to use the spacer, although with a mask any child can use the spacer, then yes, there should be extra precaution taken with these personal protective equipment, the PPE usage by the nurses.
Okay, got it. So the next question is from Judith in Pennsylvania. As a 70-year-old person living with asthma, I have not been comfortable returning to my part-time retirement job at the local Target store as a customer advocate, otherwise known as a cashier, due to COVID-19 continuing to increase in numbers. What is your recommendation? Dr. Grayson, I'd like you to take this one. Something that often gets overlooked is how many people 65 and older are still working with very unique health concerns during this pandemic.
So thank you. I mean, this is a big issue. And I think the problem here is you've got to do what's best for your health. If you're in a situation where you're in an at-risk population, so we're over 60, we're looking at an at-risk, definitely 70 plus. If the store has not provided with appropriate protection for you, which would mean that there's got to be enough distancing. I would expect, in the case of a customer advocate, that we would have plastic shields protecting you, that you would be kept away from the customers. If that's not going to happen, then going into this environment is going to put you at risk, even wearing a mask. Because remember, the point of the mask is you're protecting everybody else. And unless you have an N95 mask, now if you have an N95 mask, that's a different story. But we don't want you doing that because that's supposed to be for healthcare providers. But you're not going to be protecting yourself. And so you're going to go in a situation where you could potentially be exposed. And unfortunately, because not everyone's wearing masks, because not everyone is following the guidelines, because not everyone is making sure that they don't go out when they have a fever or a cough, we can't guarantee you're not going to be exposed to somebody. And so somebody in this kind of situation becomes a risk-benefit analysis. Now, I don't know where we get into law on what is allowed, not allowed in the workplace and what you can demand and not demand. And maybe other people on the panel know that. But in terms of someone bringing this kind of situation up to me, I would say you need to go talk to your employer. You need to explain the situation. They are supposed to, I believe, make accommodations. But I would not go into a situation where I'm going to be exposed to people without any kind of protection.
Yeah, and it's also probably a reminder for for us and everyone. It's like, let's protect Judith and everybody around us and mask up and do this for community, right? So
Absolutely.
the last thing that we want to talk about is, while working and learning at home, telehealth is also being utilized probably more than ever before. And Drs. Fox and Rastogi, Dr. Fox, I'm going to start with you. Can you talk a little bit more about the role of telehealth and asthma management, the pros and the cons, what's most important for people to know to feel empowered at home? And let's take this question from Andrea, an asthma educator in Utah. She is interested to hear more about telehealth and how to improve her asthma home visit program, virtual visits. Dr. Fox?
Great. I think a lot of folks in the audience, certainly those of us here on the panel, have had a lot more experience with telehealth in the last 6 months than anything previous. But even prior to COVID, asthma was really one of those conditions that we felt really comfortable using telehealth to monitor. And so not necessarily for acute visits, but a lot of those control sort of check-ins and follow-ups, we were starting to do some of that. And so I'll let Dr. Rastogi comment a little bit on how we've adjusted our Impact DC clinic visits to telehealth. I'll try to answer Andrea's question a little bit more directly. We started doing a pilot using telehealth for virtual home visits to address asthma home triggers in the home, and we actually started that pilot in January. Little did we know how useful this would become a couple of months later, and we've now converted all of our home visits to a virtual platform. So we use Zoom basically to do the visits, and have found them to be very effective. And I think families, one of the things that they really like is that we're able to do this initial visit and really using a standard way of approaching the visit. We have the same set of questions and almost the same set of places in the home that we ask the families to show us. And it's been very nice. I think some of our housing partners here in DC have been surprised at how much we've learned by doing these through telehealth. And certainly even for the families that perhaps will need some in-person follow-up to address certain issues in the home, at least the initial visit we were able to do through telehealth, and it's been very, so far, very effective. And so I encourage Andrea, as far as like just trying to see if you can come up with a template or a standard set of questions and places in the home that you want the families to show you. We've been able to take pictures as another effective tool to then document in the chart as to what we're seeing. And then we have developed some education materials that we then share with the families afterward to specifically address the specific trigger that we identified during the visit. And so that's also been helpful, and we can share that by email. And so it's been really nice to see how useful it's been.
Yeah, I was actually going to have Dr. Rastogi weigh in here, but I'm going to pivot to Dr. Patel, because I think it's important that as the head of the Impact DC program, the medical director, you're able to talk a little bit about the adjustments that Impact DC has specifically made and what people can learn from that.
Yeah, so I think as Dr. Fox alluded to, we were ready and prepared because we had started this virtual home visit in terms of having at least certain staff members trained to do telehealth, and that really helped us. We were able to convert in the course of a week, actually, all of our in-person visits to telehealth visits in the middle of March. Have since continued. We have one in-person visit, 1 week per day, that's in-person visits, people who are interested in in-person visits. But the rest of ours, and we've been being quite effective with doing this. I think it's also helpful to see how quickly parents are able to get the controller medications and retrieve them from wherever they are, or are they able to retrieve them? And even parents, we've caught mistakes where parents were using, let's say, their siblings' medication, and we can actually see it right in front of us, and we bring it up in front of us and we can see and correct those errors. So as Dr. Fox said, we've actually been able to do certain things better during these home visits, and have multiple partners. So sometimes during in-person visits, we'd only have one parent, and this time we can zoom in another parent if a child is split between two homes, and really make a group visit happen where both parents and both families, or a grandparent and a parent, who are caring for the child, get the education. In terms of the asthma educators, they've really liked it as well, because they get to kind of shadow each other on the visits and learn from each other in terms of how one delivers information better than the other. So it's been really helpful but also understanding that we did want to restart our in-person visits to help families who learn better in person or who wish to come in person. So it's a mix of both, and we've really enjoyed it.
Wow, sounds really great. And clinic and also being able to meet people inside of their environments, I think, is a really big new deal. So thank you so much for that, doctors. And thanks to Kenneth Mendez, our CEO at AAFA, Dr. Mitchell Grayson, Impact DC, and Children's National Hospital for their partnership, and all who've participated in this very useful Ask the Experts Q&A. Please continue to stay engaged with continuing the discussion on AAFA's social programs and our online community by signing up at aafa.org/join. You can also go to childrensnational.org and follow the link you see here for additional information on asthma triggers, medications, device instructions, and overall tips for asthma management. I'm Kafi Drexel with the Asthma and Allergy Foundation of America. Thanks so much for spending this hour with us.